Live from the ZTN studios in Harare, Zimbabwe, welcome to this edition of Heartbeat, your show on all things health. Now, recently we commemorated a World Tuberculosis Day under the theme, The Clock is Ticking. The theme served to remind the world that while we have witnessed gradual reductions in incidence and mortality rates, it is not the rate that the World Health Organization had set in the fight against TB. Now, today we carry on with this cause in keeping the promise to end TB, especially at this critical time where we are fighting the COVID-19 pandemic, which has slowed down efforts to end TB. Today's program is sponsored by the Zimbabwe Association of Church-Related Hospitals, ZACH, with support from the U.S. President's Emergency Plan for AIDS Relief, PEPFAR. Joining me in studio today, I do have guests to discuss this issue, of course, starting off on my left with Reverend Maxwell Kapachao, who is the director of Maxwell and Friends Foundation. Thank you for joining us. Next to him, we have Mrs. Otilia Makoto, who is ZACH Prevention and Case Finding Coordinator. Otilia, thank you for joining us. And we also have Dr. Manas Ncube, who is a TB and HIV officer under the National TB and Leprosy Program in the Ministry of Health and Childcare. Thank you so much for joining us.
Thank you.
Now, today we will focus on the correlationship that exists between TB and HIV and AIDS, as it poses a significant burden on Zimbabwe's health system. Now, the Ministry of Health and Childcare is leading TB and HIV and AIDS interventions with the goal of ending the pandemic. However, as it stands, about 60% of TB patients are also living with HIV. The WHO cites Zimbabwe as being among the 14 countries with a triple burden of TB and HIV co-infection, and drug-resistant TB. Now, tuberculosis remains one of the world's biggest public health threats and now ranks alongside HIV as the world's leading infectious cause of deaths. In 2019, there was an estimated 25,775 people diagnosed with TB in Zimbabwe. Of those, 4,600 died from the disease in the same year. This is according to statistics from the World Health Organization in 2019. Now, the Zimbabwe Association of Church-Related Hospitals, with support from the U.S. President's Emergency Plan for AIDS Relief, PEPFAR, through CDC, is ensuring that people have access to diagnosis, treatment, and appropriate care at the earliest stage of exposure to TB, as this is critical in reducing TB transmissions and ending the epidemic. There are no scenarios in which we can end this global TB epidemic without much greater focus on its prevention. Now, this is a very wide topic that needs to be discussed, but a very important one as well. And we may not be able to cover everything today, but I'm hoping that we will cover significant ground. Now, Dr. Ncube, let's start with you. As we begin our program, maybe you could just give us a general overview of where Zimbabwe currently stands in this fight against TB.
Thank you. As we know, the Ministry of Health has the prerogative to take care of the health of the nation. So as far as TB is concerned, like you mentioned the figures, in 2019 we had about 25,000 people who had TB, and about 60% of them happened to be infected with HIV. So this is a trend that has generally been coming down over the years in terms of both the total number of people with TB and also the proportion of them who are found to have HIV. So Zimbabwe has generally been scoring some points in that arena, and so this trend still continues. Okay. This is mainly due to good case-finding methods, strategies, and also diagnosis, care, and treatment. However, during the year of 2020, as you'll be aware, because of COVID-19, the TB program itself took a hard knock, and there were quite some disturbances in terms of continuing on this good trend. So currently there are efforts being made to sort of mitigate this negative impact due to COVID-19, and this is still ongoing.
Okay, just out of curiosity, so we realized that, of course, in 2020, a lot of services were suspended or faced challenges. Did we witness an increase or a reduction, or were the cases just stagnant?
Thank you. So in terms of those who were diagnosed with TB, the numbers really came down. So compared to the figures from 2019 and 2020, we actually had a drop of 27%. We know that there is more TB than what we found in the community. So some TB cases were missed, mainly because of COVID-19 and the related mitigatory measures to control COVID-19. Okay. So the program did not perform at its best during the year of 2020.
But it continued to perform?
Yes.
All right. Otilia, let me bring you in. Now, what role does ZACH play in this entire fight? We are fighting to end not just HIV and AIDS, but also the co-relationship between HIV and AIDS and TB. Where do you come in?
Thank you. The Zimbabwe Association of Church-Related Hospitals is the medical arm of churches across the country, and we are complementing Ministry of Health efforts to ensure that services reach the intended beneficiaries. And we are working mainly in the hard-to-reach communities, in rural communities, and in community posts here in Harare, recently established, where we are aiming to reach all the intended clients with the services. That includes HIV care and treatment, including TB. There is a thin line between HIV and TB, and as such, we are getting support from PEPFAR to ensure that all the clients that we are working with and having to receive our services are receiving comprehensive services, which include TB services, to ensure that there is enhanced screening for TB. There is also enhance the reach for TPT medicines, as well as infection prevention and control. So as such, that's where we come in, complementing Ministry of Health efforts to ensure that the services for HIV and TB reach the intended beneficiaries.
All right, thank you very much. Now, we will be aware that, of course, the treatment process is not as straightforward as, you know, going to the hospital and just getting a bunch of pills. It is a bit more intense. It requires a bit more effort and a bit more help and support from especially our communities and our families. But we did get Nurse Irene Nyandoro, and she was kind enough to give us a bit more insight into how they deal with TB cases from the point where somebody is diagnosed throughout the treatment process. Let's take a look.
When a client tests positive for TB, what we do is, for the first 2 weeks, there's what we call direct observation treatment, where the client comes to the clinic on a daily basis for medication, and the health worker observes the client taking their medication so that there's proper adherence. And after those 2 weeks, we start giving 2-week supplies. So the client is initiated on what we call RHZE, which is a combination of 4 drugs. And this is taken for 2 months, which we call the intensive phase. After those 2 months, we collect a sputum for AFPs, and if it comes back negative, we switch the client to what we call HR, and these are 2 drugs. HR is taken for 4 months and is called the continuation phase. We also do a sputum at 5 months and also at 6 months. If it comes back negative, we discharge the patient from TB treatment. What I just explained is the treatment for pulmonary tuberculosis. There is what we call extrapulmonary TB, which can occur outside of the lungs, and this can be abdominal TB or spinal TB. So treatment for spinal TB and abdominal TB can last as long as 8 months. It's longer than treatment for pulmonary TB. Then there's also what we call drug-resistant TB. The medication for drug-resistant TB is prescribed by the doctor because it's complicated, and it can even last as long as 1 year or more. So maybe I'll explain first what TB preventive therapy is. TB preventive therapy, this is medication that we give to people living with HIV as a precautionary measure to treat latent TB infection. And this is taken for 6 months. At this facility, we give what we call isoniazid. And this isoniazid is given simultaneously with pyridoxine to prevent peripheral neuropathy. And it protects the client for 3 years. So to make sure that everyone is initiated on TB preventive therapy, what we do is we screen every client on every clinical visit for eligibility. After screening client for TB, we offer client IPT, and we also make sure that the client does not have contraindications for TPT. These contraindications can include liver disease, hepatitis, or even excessive alcohol intake. Because if a client has excessive alcohol intake, it can lead to hepatotoxicity. And we also make use of stickers, like at this facility. For all our client booklets, we use stickers, blue stickers, to indicate clients that have taken IPT. So if a health worker sees a client booklet that does not have a blue sticker, definitely she knows that the client should not take TPT, and they offer TPT to the client. And we also make use of outreaches where we target those who are hard to reach. And this is done in collaboration with SACH. They provided with the resources, and we do outreaches where we give TPT. We also do viral tests and do artery supplies as well during the outreaches.
All right, so as Nurse Nyandoro had mentioned, that it is a process that can take anywhere from 3 months to a whole year, depending on what you're battling exactly. Now, Reverend, you are a survivor of tuberculosis, and we are going to go into depth about that a bit later on. But for now, could you just explain to us briefly your experience with TB treatment? What were some of the things that you felt while you were on treatment, the process itself, and do you feel as though you had the adequate care?
Thank you so much for that. Really, as far as we know that TB is treatable, and TB, when once treated, you'll be okay for good. But really the journey is not comfortable. The journey is cumbersome. The journey is so stressful. In my case, I suffered TB twice.
Right.
Yes. So it wasn't pleasant. The first time, it was not pulmonary, but it was abdominal. And if you look at it in the African context,
yeah.
But there were a lot of things that happened during that time. Even the doctors did not understand it. Up until from the clinic that I was taking my heart medication, they referred me to Nazareth.
Right.
They again at Nazareth, they said, no, you are not a client for this place. You need to go to Salim Gabe Hospital.
Right.
Yes, there are fluids, yes, and the only thing that you need to be drained. Up until one person said, no, guys, let's respect the institution that referred this person to us. So they started me on 1 week treatment. But the senior doctor was saying, when I take these TB medicines, then that will help. Is I can throw out water frequently.
Right.
And that will be helping. But the first thing was, no, let him go and get this fluid drained. But then the senior doctor is saying, okay, fine. He can be drained, but had we closed the tap, what has caused it?
Right.
This is TB. Even to me, when he said it's TB, it was so funny. I did not understand it. So really, I moved up to 8 months treatment.
Right.
And I think 3 years down the line, I was down again with TB.
Okay.
And I did not understand it that time. I had sputum tests, it came out negative until I had to go for an X-ray test. That's only now they said, no, this is pulmonary. That one now was heavy because I had to go for 60 injections.
Oh, okay.
So 1 injection per day, you take your TB tablets, you are taking your ARVs. So it also became pure burden. But because I needed to survive, this is what has been on the table. I made sure I completed the 60 injections. How did I complete them? I need to fall back on the family. I need to fall back on the community. I need support from very close friends. Otherwise, on your own, I don't see you managing to go every day for 1 injection, every day for 1 injection, up until for 60 good days.
Yeah.
So without that support, I don't think I was going to make it.
Right.
But well, thank God. Even when reflecting back, you talk to somebody who tell you 60 injections is a non-starter.
Right.
Yeah, that's the process, but you can survive. So I made it, and in 6 months, I was clear and clean. And this is almost now 11, 12 years ago.
All right.
Yeah, yes.
So we have a positive story. But now, Otilia, let me bring you in. When he started to explain the process, yes, we have come a long way in terms of how we diagnose TB and the methods used. So I'm sure the process now is a bit shorter. But how does Zach help to make sure you're not being transferred from one place to the next because they're unsure of what it is that you're dealing with now?
So as such, at the facilities where we are supporting, we are ensuring that the services for screening are available at the sites. And also we are ensuring that the clients are having their medicines readily available with support from Ministry of Health, pharmacies. We are also ensuring that our the healthcare workers that are working at these facilities are well capacitated and knowledgeable to ensure how to be handling these clients who present at these facilities so that they get the rightful attention and treatment which they need. So we are also complementing to ensure that the required cadres or staff are there at facilities in the HIV care and treatment support services to be attending to these clients with the support that we are getting from PEPFAR. We ensure that all the clients who have got their sputum or specimens collected are transferred to the labs where they are supposed to be tested if there is no lab that is available. But in most cases, these tests are now done locally at the facilities where the clients are. So we are making sure that the clients are receiving the rightful care and treatment which they are supposed to be getting at the facilities where they are being served.
All right. Are you at liberty to tell us how many institutions you're currently working with?
As such, we are working with 75 facilities across the country, mission hospitals and some government clinics. We are also having 6 community posts that are here in Harare, in the marketplaces where there are a hive of activities, where clients are not maybe going to be having time to be visiting the clinics or hospitals because of the nature of the work which they do for their livelihoods in the markets. So we are ensuring that the services go to where the clients are so that they get to be screened for TB. They also get to receive the medicines which they require, and also we are ensuring that TB preventive therapy medicines which are required by these clients, if they are eligible for getting these medicines, they are also available at the facilities where we are working with.
All right, thank you, Today. Now, speaking of the TPT, now, of course, if you're living with HIV and you receive this TPT, your chances of contracting tuberculosis are significantly lower. What is the importance of this drug, and how do you identify who needs to have it and who doesn't? Dr. Ngube, let me come to you.
Thank you very much. So with TPT, basically it stands for TB preventive therapy. So as the name says, you are preventing TB. Many people, the majority of the people, particularly in this part of the world, are already infected with TB. But being infected with TB doesn't necessarily mean that one will end up with the TB disease itself. The germs are only in the body, but they're not causing a disease.
Okay.
But there are some groups of people who are sort of at a higher risk of then going on to develop the disease. And people living with HIV belong to that group, and they form the better bulk, if you like, of the group.
Right.
Up to 37, up to 40 times more likely to develop the disease. So for that reason, TPT now comes in to prevent that progression from the infection to the disease. So the major groups that stand to benefit from that, it's people living with HIV, and then people who have been in contact with people with TB. Some groups of people, not everyone, but close contacts, particularly those who are diagnosed with TB, and it's found in their sputum, because when they cough, the TB then goes into the air, and it's easy for the next person to breathe it in. So those groups, people living with HIV and people who have been in contact with people who are found to have TB in their sputum, those are the 2 major groups who stand to benefit most from this preventive therapy. So this preventive therapy has been ongoing since around 2011, 2012. So we've had this for about 10 years now. But what has changed is the options available for purposes of preventing the TB disease itself. So depending on the background of the person, what's their age, are they living with HIV, are they not living with HIV, which ARVs are they taking, it determines which combination of TB medicines they are going to take for purposes of preventing TB disease. Over and above that, we are happy to say now there are options that take a shorter duration in terms of how long one needs to take them to prevent the TB. Like she mentioned, generally we've been using the 6-month regimen, but now there are newer regimens that are taken only for 3 months, just once a week, and some for 3 months every day, depending on those dynamics that we mentioned. But ultimately is to prevent progression from infection to disease. And as a program, this is what we are promoting now, and we're trying to roll out into the community, because it's a relatively new regimens or options that we have in our basket.
Okay, Doctor, are these options now also available for rural communities, and how is the ministry getting rural communities more educated about tuberculosis and how to take care of those who have it and how to prevent yourself from getting it if you're in contact with them?
Thank you. So like I said, at the moment, the preventive therapy has been there for a decade or so. It has always been available for all this time, both in urban and rural areas.
Mm-hmm.
But in terms of the options available, these at the moment are limited in terms of availability.
Okay.
There are some centers in urban settings, there are some centers in rural settings who have access to these options. But at the moment, it's really at a limited scale.
Okay.
And then in terms of information dissemination, this is happening, this is ongoing at facility level, in our clinics, hospitals, and so on, and also in the community through different means of reaching the people, through media, campaigns. We also have community health workers who are able to disseminate some of this information. So using the means available, information we think is reaching the people. Okay. Under the circumstances.
All right. Now, Otelia, of course, we will recognize that we have, we are dealing with TB in a very specific and very special time. We are dealing also with the COVID-19 pandemic at the moment. How has lockdown, when we look at most of 2020, we were in lockdown, recently came out of it, but looks like we might be heading back into it again. How has COVID-19 affected your operations as such, especially when you're looking at your mandate to help end TB?
Thank you. As such, our mandate has not been heavily impacted as far as ensuring that services reach to the intended beneficiaries. We are still continuing to see that clients are saved. Screening for TB is ongoing. Those who require TPT are issued with TPT, and those who require some support do get the support they need. However, when it comes to clients' mobility, COVID-19 has been restricting clients' movement, where clients who require maybe to get their reviews and get screened for TB have reduced the access to healthy facilities. But we have been having strategies to ensure that as such, clients are continuously reached in the communities where they are through outreach activities, where we have been taking the medicines to where the clients are. Mm-hmm. We have also been having the clients screened even during outreach activities to ensure that those who are eligible for getting the TPT medicines do get the medicines. However, we still have that scaled down regarding how we would have wanted to reach our communities because of the impact of COVID-19. But we are still going on. We are still trying to reach out to all our clients to ensure they continue to get their medicines, they continue to get screened, they continue to be referred to where they are supposed to get the services which they do need to get.
All right, and I'm going to assume that when you say you really haven't been affected much, you're also including the rural communities and your operations there?
Yes. Regarding our reach to the clients, we are mainly in rural areas. Like I said, we are targeting those in the hard-to-reach areas, in rural communities and in the markets where they are there always to try to fend for their living. So we are going there to ensure that the services reach them. However, with COVID-19, these markets will not be having people. There will be restrictions for them to move, so we will not be reaching out to them to ensure they are screened and they are given information, because one of the activities that we are doing as such is to ensure that the clients and the communities do get information on HIV and TB and get to understand that TB is preventable, TB can be cured, and anyone is at risk of getting TB. So that information is continuously being shared with the communities where we are, and the COVID-19 restrictions is just limiting our reach to the people, as we will not get them as many as we would want because of the restrictions that will require them to be staying at home. But regarding reaching them, we are still making efforts to ensure that with the support we are getting from PEPFAR, we are going to where they are through the outreach services like I've alluded to earlier on.
All right, thank you so much, Atilia. Now, Reverend, I hope you're free to share with us. How did you contract TB? And what are some of the symptoms that you experienced prior to actually going to the hospital? I know you first mentioned was there anything else that you felt that had you a bit concerned before you went to the hospital?
Thank you. Really, sometimes it's so confusing because I never thought, like in the first instance, I never thought that could be TB. But I realized one thing that has been so dangerous and very, very, very not good, especially to somebody who is also on art, stress. During the time that I had this problem, and I had a very hard time at my workplace. So I stressed so much. And the next thing was to see my tummy bulging. And the coming thing, I'm told this is TB. You know, at one time to me it did not make sense.
Right.
So, especially as long as you are living with the HIV, please, we need to try and exercise stress management. But stress is not good to someone who is like me today, who already, my body is already fighting something.
Right.
And I stress it out.
Right.
So on the second occasion again, I don't know, I only started feeling weak. No, just be saying, no, I don't have much appetite, but I'm not having these night sweats, I'm not having these, but, and you start wasting away, you know? Even to imagine, to say, could this lead to TB? To me, it was not it. I was not even coughing.
Right.
You know, most of the times we think whosoever is coughing then is a like candidate of TB. But in my case, it wasn't like that.
Right.
And also, I think that this should also be a wake-up call to some of our health institutions. Because one thing that is mostly done for free is when they take your sputum, it's done for free. Anything else after that, you need to pay.
Right.
In order for them to investigate. You see, I come to a health facility, I'm telling them this is what I'm feeling, but then I have to pay for the x-ray. To which it demotivates whoever is feeling in that time.
Especially if you can't afford it.
You can't afford it.
Right.
Exactly, you see. You could be having every sudden symptom, say this could be leading to HIV, but the doctor really wants to fully confirm. But then I'm asked to pay for that service. And once that is done, and it confirms that, okay, this is TB, whether it's an x-ray, this is TB, I'm enrolled on TB treatment. For every review, again, I have to pay. Then we said, why? Why should I pay? Yet we say TB treatment in Zimbabwe is free. Automatically, when some of these services now have been asked to pay, already,
it's not free.
Yeah, it's no longer free. So this already drives somebody to go underground. And imagine, I could not be helped in Harare. I had to go to Chiweshe.
Right.
Yeah, I had to go to Chiweshe. This is where those things have to be done. And that's when I had to go for... It was only picked in Chiweshe, my second attack. It was only picked in Chiweshe. Then I had to come back to Harare now with everything and to my nearest clinic. But in order for that to be done, the x-rays and whatever, they were done in Chiweshe. I couldn't afford to do them here.
Right.
You see. So already that's a barrier. As much as we want people to have to be treated on TB, but once there is that thing that demands you to pay something, it's a barrier to this service. But really, the journey has not been easy, and we still hope whoever is within the policies to at least please, if that cannot be revisited, we'll continue getting a lot of people going underground. Yeah.
Actually, while we're on that, Dr. Ncube, what are your thoughts on that? Because he has raised a very valid point. If you are coming from a community or rather a household and you can't afford to be paying for x-rays, you can't afford to, it means you're going to fall under the radar. Are we looking at ways to, I don't know, subsidize some of these fees that need to be paid for, especially for TB screening?
Okay, thank you very much. So as part of the broad strategy for Ministry of Health as far as TB program is concerned, indeed there is a drive, like we mentioned, that we picked up less cases compared to what we estimate to be TB in the community. There is a program where outreaches are done into the community, where screening is done for free, not just for TB, but TB, HIV, COVID-19, breast cancer screening, and other conditions, diabetes, hypertension, you name it. So there's that sort of composite program where many of these conditions are attended to. But like he mentioned, there's still a challenge to say at times when people have to access healthcare before it's confirmed that it's TB, there is a challenge on the issue of payment of user fees and so on. So this is something that is still being looked at, but there's some effort that is ongoing to be able to help people be able to access especially the important, the very essential services without having first to dig into their pocket to access that service. But in terms of treatment, generally TB treatment is free, but it's the diagnostic element that improvement is still ongoing in terms of people improving access to those diagnostic services.
All right.
Beyond just the sputum test.
All right, thank you very much, Doctor. Now, of course, despite the resilience, TB programs have been impacted by the COVID-19 pandemic, which is threatening to reverse the gains that have been made towards achieving global targets. Now, we take a short break, but when we come back, we will be speaking to, or we'll be hearing from Linda, who is a TB survivor, and she shares her story with us on how she contracted TB, how she survived it, and what she went through during the time that she had it. Now, of course, remember that this program is brought to you by Zimpaper's TV network in partnership with the Zimbabwe Association of Church-Related Hospitals, ZACH, with support from the U.S. President's Emergency Plan for AIDS Relief, PEPFAR. We will be right back. Don't go anywhere. Welcome back to this edition of Heartbeat. We are keeping the promise to end TB. Now, Zimbabwe is among the 30 high-burden TB HIV countries. And sadly, while most deaths from TB are preventable, the death toll from the disease is still unacceptably high. And efforts to combat this must be continuously accelerated. Now, we managed to track down a TB survivor. Her name is Linda, and she shared her story with us. Take a look.
Nekuti ndisingafambi pandakabatwa neTB ndaigara mvura ndaenda kuchipatara mvura day rekutanga ndakaenda vananzi hatina zvatiri kuona day 2 vandaenda vananzi hatina zvatiri kuona day 3 vandaenda ndopandakazonzi ndine TB ndichibva ndaadhimitwa ikoko kuchipatara ikoko asi zvangu zvakaoma ndiri muchipatara imomo nokuti mapiritsi chaona asingagoni kana kumana ndaitoisirwa mukagaba onyungudiswa ndozonwiswa ndotobatiranwa ndonwiswa. Pandakazopora ndakazoudzwa kuti ndaitoita unge munhu akupenga ndiri imomo zvokuti ndiri muchipatara imomo asingafungidziri kuti ndichazobuda ndichifamba nekuti ndairwara kana kumuka kugara ndega ndasingagoni kudyiswa zvese kugezeswa zvese ndaitirwa ndiri muchipatara imomo. Ndakagara mumvuri 1 month ndichirwara pandazotransferiwa ndaka kuno kuairport. Ndiri kuno kuairport ndinobvira ndauya kuchipatara ndaivingwa kumba na sister Chigwada na sister Fadzi na sekuru Brian ndovaiuya kumba nemotikari yeZACH vakandibatsira nekuti nguva yacho yona asingagoni kufamba transport pampasina asi zvese vaiva vachindiitira kumba. Ndinongotenda kuti zvangu zvakanaka nekuti vangu vasingandisemi kuti ndiri kurwara neTB vaindibata zvakanaka vaitwa paya kumba ndichitowanetsa kuti ndoda mapotatoes vaitosiyiwa ndipa mari yacho yemapotatoes wotengera ndotobika kumba nchidya. Ndinongokurudzira vanhu vari kurarama vane HIV kuti inouya mapiritsi ekudzivirira TB nekuti machances ekubatwa neTB akakurisa kumunhu anorarama nechirwere cheHIV. Saka kuno mapirisi ekudzivirira TB kwakanaka.
Now, Linda's case sounds a bit as though it was on the extreme level, wasn't it? But it's not an uncommon case either. Otilia, how do we get to a point yokuti munhu anorwara kusvika kuita kunge akupenga? What has happened during that process? Is this a case that went under the radar for too long? What happened exactly with Linda?
Okay, thank you. With Linda's case, this client looks like maybe possibly akanonoka ku diagnose kwa kuti aoneke kuti ane TB, anga arwara for a longer time, and at the same time she was having HIV, and she needed to get the treatment so that her condition could improve. So it was an issue of possibly having to delay to be diagnosed that she had TB, and also in addition to anga and HIV, then it worsened her situation. That's what happened to Linda. But I'm happy she highlighted that at the end of it all, she got treatment, she got to recover, and now she's a living testimony of surviving TB, which is what is important, and would want our communities to know that they can still do well, and it's good for them to get diagnosed whilst it's early, and also to get their treatment, adhere to their treatment, complete it, and they will be fine once again.
Now, Reverend, so we've heard Linda's case and we've heard your case, and they do sound very different. They have one similarity in that they went to different centers and both of them were told, oh, we can't really see what's going on, and it was later on found. But Reverend, there's something that you mentioned in the beginning that I want to talk to you about. You are a reverend, you are a Christian, but you mentioned pekutanga kuti one of the first thoughts was akaroiwa. How did religion play a role in either getting you diagnosed on time, or did it prevent you? What were the dynamics there? Because kuroiwa chivanu and you are Christian. Where did these two worlds come together?
Well, thank you so much. Really, there is something that is very good with religion, and we are coming from communities that believe in different religions. But honestly, when it comes to the issues of health, especially with TB, if not properly packaged, if not properly handled, we will miss the mark, and we will continue losing a lot of people because of our religious beliefs. For me, it was the family against my religion. Part of the family is saying we have to do it the traditional way. But my conscience is telling me, no, I cannot do that because I'm a Christian.
Right.
So already it's a tug of war. And then normally when such things happen, you are at the disadvantage. Why? Because most times you are not financially stable. So the very people will be pushing to their own, what they believe. Right. Condition we don't have such type of things even in our family history. It's either and it's not going to tender ku this other. But honestly, coming also to on the scientific side, now we are saying I cannot do this because of what I believe, and I have to go to a medical center. I have to get this thing being looked at and all that. Once there is disintegration within a family, most times you are left alone,
right,
because of religious beliefs. At the same time, religion is a good vehicle that can be used in our communities to disseminate proper TB information. Religious leaders, if they are empowered enough to know the dynamics of TB, how it can affect somebody, to know that TB is treatable, to know that TB is not only a one-line thing, but TB, you can have TB of the lungs, you can have TB of the spine, you can have TB of this. If that message can come to these religious leaders and community gatekeepers, definitely we would see a decline in most of these cases. To reach at a point, at another point, you would see that most of these cases, it will be delayed diagnosis that will lead somebody to be bedridden. At the same time, this person is also on art.
Otilia, I saw you. You want to contribute. But
Thank
also, while
you.
you're contributing, I actually did want to ask you, have you had to deal with this dynamic in communities, and how has Zach handled it if you've had to come across them?
Thank you. You went right to what I wanted to get in with. Writing on what Pastor Kapachawe has just said, as such, we are working in the communities. We've got a program, the Faith Community Initiative, where we are working with faith leaders to give them information on HIV and TB, and also to empower them with correct and proper information that they can disseminate in the churches, so that people get to understand more about HIV, also to know more about TB, and also the issues of stigma to be addressed through the churches and through different faith communities. We are not only looking at the Christianity, we are looking at various religions, where we are bringing everyone together, having to discuss these issues, so that they get to understand that together we can work on these challenges which we are having as a family, and get to resolve, and at the end of the day have our communities healthy once again. So as such, we are having support from PEPFAR to be working in the communities with faith leaders, traditional leaders, to give them information. We have trained them, and they are currently working on disseminating these various messages in their various religions, so that at the end of the day we have empowered faith leaders who are able to cascade the information on HIV and information on TB.
Okay. Now, TB and COVID-19, Otilia, tend to share symptoms and similarities here and there. And often that can be a very confusing thing, especially in the time that we're in. And the first thought will be, oh my God, I've got COVID-19, but you've got TB. How is Zach helping to, and I will bring this to you as well, Dr. Ncube, how are we working to make sure people are clear on what symptoms belong to which disease, and what message are we sending out in terms of just getting a clear diagnosis and treatment? Otilia.
Thank you. True that TB and COVID-19, they sort of like confuse in terms of the diseases affect the lungs. Both do affect the lungs. Both do share the same symptoms. So as such, what we are doing to ensure that our people get to understand the differences between TB and COVID-19, we are empowering the community workers and the clinical staff working at facilities with information that they need to disseminate to people, so that they continue to seek services when they get any symptoms, either for TB or for COVID-19. So the difference between TB and COVID-19 symptoms is that with TB, usually you have a productive cough, you can cough up blood, and also you can have a sore throat. While with COVID-19, you may not have these, but they say the same symptom, like having a cough, you can have a cough with TB or with COVID-19. You can have a fever with cough with COVID-19. And also the other difference is that with the TB, it has a longer duration. It progresses over a long time as compared with COVID-19. So the onset of TB may be prolonged to start showing symptoms, but for COVID-19, someone can show symptoms within a shorter period of time. And it has also been shown in studies that those who have got TB have got usually they have some more severe symptoms of COVID-19 than those who do not have TB. So that's why we are encouraging communities to always have their screened for TB, so that they are put on treatment if they've got TB. If they do not have TB and they've been exposed, they get to receive TB preventive therapy. And those who are living with HIV, we are giving them information that they need to get the TB preventive therapy if they are eligible, so that in the event that they get COVID-19, it may not be as severe as it would be if it was diagnosed when they had TB, which has not been treated. Okay. So that's what we are doing in the communities, and we've got community cadres who are working with us, the faith champions who are disseminating information on TB, the clinical staff we have been trained. We are working with Ministry of Health to ensure that clinical staff at facilities are capacitated with the right current information on TB, so that they cascade this to the clients which they serve.
Okay. Dr. Ncube, same question to you.
Okay, thank you. So like she mentioned, both of these diseases basically are mostly going into the chest. So for that, both will cause a cough. One might be short of breath. It might cause fever in either. So there are those symptoms that won't really distinguish one from the other. But there are some that are sort of more aligned to TB, for example, the weight loss over time. But COVID-19 is more of the sore throat, and like she said, it's a rapid disease generally. So I think the take-home message for our viewers is don't make the diagnosis at home, but instead seek health care from trained people who are able to then to administer the right tests and make the right diagnosis. It might be TB, might be COVID-19, might be both, might be neither. So the important thing is to then seek health care with trained people who can then separate these and manage accordingly.
Oh, just also very quickly, so we've really been looking at this from a scenario of somebody who has neither TB or COVID-19. But what happens in the incident where I'm already on TB treatment and I start to experience, or rather I then get COVID-19? How do I tell that my situation actually requires additional, additional care? I might just go on thinking that maybe it's the TB that's gotten worse, or it's a process of me getting better. How do I know that I actually also have another disease to deal with?
Okay, the principle of treatment generally still works when it comes to someone who has a problem with their chest and TB has been diagnosed. They go on TB treatment. We anticipate to see them improve. It doesn't take a long time to see that, fine, they are not well yet, but there's some improvement that is happening. So if the improvement is not seen, then there is need to revise and say, could there be more than what we just diagnosed as TB? So usually when people are taking treatment, they are regularly monitored to see if there is improvement, to see if there is side effects, are there other conditions that need to be attended to. So that is why it's important to stick to the treatment, but then honor the reviews and be able to be monitored and corrective action taken if need be.
All right, Otili, you want to add on?
In addition to what Doc has just said, studies have shown that TB has got, those who have got TB are at 2.1-fold chance of getting COVID-19. And so what it means is those people who are having any signs and symptoms that may be associated with TB or COVID-19, the best way is for you to go and get a test.
Okay. Regardless of what you think you have,
Yes.
just go and get tested, go and get screened. Better safe than sorry.
Yes.
Now, Reverend, we still have a situation where there is a lot of stigmatization in society for somebody who has TB and even somebody who has recovered. How was your reintegration into society after you were well? How was the process for you, and what were some of the challenges that you faced that you think can be fixed?
Yeah, really, it was a double problem, a very double challenge to be reunited back with the community, to be reunited back even with the family, with the Christian family, with your faith anyway. Stigma really lingers on people with TB. It's bad. Why it has been so is because over time our people had been drilled to understand that whoever has got TB automatically is equals to HIV. But is that really a true message? Because understand, Doc said about 60% could be having HIV. So, but there is a percentage that can have TB without having HIV. But automatically, when you present yourself to the family, when you present yourself to the community that I am on TB treatment, the next thing is test for AIDS. So automatically then stigma comes in.
Right.
To which we have a long way to go. But first and foremost, what really helps me as a survivor, what really helps me as someone who is on TB treatment, is I have to come out of the shell, I have to come out of what we call self-stigma. Because the moment I entertain self-stigma, I won't be able to share anything with the community.
Right.
I will go underground if it means I'm taking my medication, or most times I would not even want to go and have those tablets.
Right.
Why? At the end of the day, it's not TB that has killed this person, but it's the stigma. To which we have a role to play as people. I have to make sure that no matter the name calling, no matter they do what to me, I have to stand my ground and say, yes, I'm on this treatment, and I know it's for 6 months, it's for 8 months. One day it will be over.
Right.
So I have to start by believing in myself. Also, disclosure, it helps us. Because everyone is vulnerable to TB somewhere, somehow. All of us were exposed, you see. And all of us, we need, knowledge is power. What makes our communities stigmatize us is because they don't have enough knowledge of what it is exactly.
Right.
But once that knowledge is there, this is why I'd always also challenged our religious leaders to take the lead when we have such situations. But at the end of the day, whoever is sick, whether it's HIV, it's TB, they end up at the church.
Right.
But what message does the leader there has for this person?
All right. Thank you very much, Reverend. You want to add something very quickly? I'll give you 30 seconds.
No.
No, you're good? All right. I thought I saw your hand up. All right. So now, of course, the CDC and partners are working to reach the United Nations goal to ensure that at least 30 million people, including 4 million children under 5, 20 million household contacts of people affected by TB, and 6 million people living with HIV receive TB preventative treatment by 2022. As we round up our program today, bearing this in mind, I will start with you, Dr. Ncube. How do we as a nation meet this target? How do we accelerate efforts to eradicate TB in Zimbabwe, especially considering that 2022 is really around the corner? So I will start with you, and then I will bring it to Reverend, and Otilia, I will conclude with you.
Thank you. So these targets were set up in 2018. So since then, Zimbabwe has been making sterling efforts in terms of making sure that people living with HIV access this preventive therapy together with the other risk groups that we mentioned earlier. So this is something that has been rolled out. TPT has come in to bolster that. But sad to say, during the year of 2020, the activity sort of slowed down because of things to do with COVID-19 mostly. But I'll say counting from January 2012 to end of 2020, we had managed to give courses of up to close to 600,000 for preventive therapy as a country. So we already have targets for 2021, 2022, 2023 in terms of coverage for this TPT, riding on those targets that were put globally, as it were. So the preventive therapy is still being rolled out. The new regimens are coming in, and there's a deliberate drive to make sure that coverage increases even in the face of COVID-19. There has been challenges in terms of drug supply because there's been interruptions in terms of manufacturing and so on. These are some of the challenges that have been faced. But preventive therapy is still ongoing under those circumstances.
All right. Thank you. Reverend?
Well, always it's good to put on targets. It's good, but reaching them, really, sometimes it needs a lot of muscles. But we thank God. We commend our Minister of Health. They've been doing a very good job. And we just need to tie here and there the knots, especially when it comes to people accessing these TB services. Really, we wouldn't want a scenario and a situation whereby one has to go 3 times, 4 times before finally is put on medication.
Right.
Why can't it just be done under one roof?
Right.
Then automatically. But these delays, it becomes something else.
Right.
But above all, TB is treatable. And honestly, a loss to one person due to TB is a loss to us. There is no reason why people should die of TB, which is very curable. I am a survivor. I am a TB champion in Zimbabwe. I am a survivor, and there is no point, there is no reason whatsoever for people to continue dying, despite whether HIV negative, HIV positive. Everyone is vulnerable to TB. But we can minimize. We don't want these deaths related to TB.
All right. Thank you very much, Reverend. Otilia, finally, let me conclude with you.
Thank you. As such, through the support we are getting from PEPFAR through CDC, we are continuing to work with Ministry of Health to ensure that we scale up efforts to increase number of clients who are going to be receiving TPT. And also we are capacitating clinical staff so that they have proper knowledge, proper information. We are also having community workers working in the communities to continue spearheading the objectives of the TB program and also the HIV activities. So as we go towards epidemic control, we are working flat out to ensure that efforts are really stepped up to ensure clients do get their medicines, do get screened, do get the TPT, and also infection prevention and control measures are put in place at facilities where we are. And we are hoping together we will make it and TB will really end at one point in time. And to our viewers out there, I would like to say, as Pastor has said, TB is preventable, TB can be cured, and there is no reason why anyone, HIV positive or negative, can die of TB. Let's go for screening. Let's remind our caregivers to be screened for TB. Thank you.
All right. Thank you very much, Atilia. Thank you to our viewers for joining us as we held this edition of Heartbeat. And of course, our topic for today was keeping the promise to end TB, where our focus was looking on the milestones and the challenges that we have faced as a nation in eradicating TB entirely. Now, thank you, of course, to Nurse Nyandoro as well as Linda for talking to us and sharing their experiences in this fight against TB. Now, this program was brought to you by Zimpaper's TV network in partnership with the Zimbabwe Association of Church-Related Hospitals, ZACH, with support from the U.S. President's Emergency Plan for AIDS Relief, PEPFAR. My name is Candace Mwakaliele. Be kind to each other, but be kinder still to yourselves. We'll see you next time.